Good day to you all. Thanks for coming. I'm Dana Iorio. I'm a family nurse practitioner from the Adult Medicine Clinic here at Harborview. I would like to thank the Harborview Ethics Committee for hosting this forum on this important subject that is important to Harborview as well as the rest of the healthcare institutions in the United States. Healthcare reform that is trying to address access to healthcare as well as costs is an ongoing and never-ending battle in the halls of Congress, in the workplaces of America, in the healthcare institutions, and the healthcare provider meetings that we all attend, and in the communities across America. Healthcare reform is an issue. So today's forum will touch on some of the ethical considerations of healthcare reform and hopefully spur discussion on where we can go from here to bigger and better things. Maybe not bigger. The format for today's presentation will be a series of questions asked of our esteemed panelists. They will each have 3 minutes to respond to each question. This will be followed by a 5-minute audience question and comment period for each question. So on that note, I would like to introduce the moderator of this panel, Hugh, who will introduce the panelists and pose the questions. Hugh is one of Harborview's distinguished, accomplished, and excellent general surgeons, and a decent human being overall.
That's the most important.
Originating from Nebraska dirt farmer ancestry, he served in the military and got his MD at University of Nebraska. He did his postgraduate training at University of Washington and has been on staff at Harborview for nearly 25 years.
And pretty close, yeah.
Okay. All right, take it away.
Thanks, Dana. It's a real honor to moderate this session. Healthcare reform is something that is near and dear to my heart. I think many of us choose to work where we work due to what we perceive as the mission of that institution. Those missions, as does the whole landscape for healthcare in this country, have seen innumerable changes. Some of them glacial, some of them sudden. But if you think you're doing A, it turns out maybe 15 years later you're doing B, which was never your intent. But nevertheless, I think one of the things that I think we have in this community, particularly the Harborview community, is a real esprit de corps and dedication to our mission. And over the years we have partnered, myself being an educator, we've partnered with our neighbor institutions for that endeavor, both for education and for patient care. I have to thank Swedish Hospital for changing this surgery residency program from an every other to an every third night program about 35 years ago, which was a huge improvement for resident well-being. I'm very honored to introduce our panelists, who are a very esteemed group of very dedicated people in their fields and also their contribution to the medical community. On my immediate left is Dr. Sherry Weinberg. Sherry went to Swarthmore College and got her medical degree 1977, but who's counting, and we met in 1978 when I showed up here as an intern, and she was a pediatrics resident. Sherry practiced pediatrics in the greater Seattle community for many decades, and she's been a very ardent supporter of healthcare reform, and she currently serves as the chairperson of the Western Washington chapter of Physicians for a National Health Program, which is a national organization of over nearly 30,000 people strong, not only physicians, but people from all walks of life, although the nucleus of that organization came from the people who started the Medical Committee for Human Rights, which was the physicians' arms of the civil rights movement back in the 60s. So we're very honored to have Sherry as one of our panelists. To her left is Dr. John Henson. And John is a neuroradiologist and neuro-oncologist and currently the Chief Medical Officer at Swedish Medical Center just across Bourne Street here. He is he went to Loma Linda for medical school, followed by his neurology and neuro-oncology training, and then was on the staff at kind of a second-rate institution perhaps in Boston, the Massachusetts General Hospital, where he served on the attending staff there as a neuroradiologist and neuro-oncologist for over 17 years. And we were fortunate to lure him here to the Seattle community, where he now works at the Neuroscience Institute at Swedish Medical Center. He's also has an executive MBA from the UW Foster School of Business, so he's well versed in all aspects of healthcare, both on the delivery and the administrative side. To his left is Katz, and anybody who knows anything about healthcare administration, public health, or healthcare reform in this community knows Dr. Katz very well. Aaron is a distinguished lecturer at the University of Washington School of Public Health, is quite well versed in issues of global health, healthcare delivery, and healthcare reform. As he's ridden out, as he says, more than 3 major typhoons in that regard over the 30 years as he's been a scholar and a researcher and a speaker on various aspects of healthcare reform, which have included weathering the HIV/AIDS epidemic in this country and also worldwide. He's been helped and consulted on healthcare administration and arrangements around the globe in sub-Saharan Africa, Latin America, and as well as Japan. And he's a reviewer of many journals in his field, an engaging speaker, a wonderful person, and so we're very fortunate to have all of them here. So I give a round of applause to our distinguished panelists, I think, who have a great perspective from many sides on the issue of the ethics of healthcare reform. As I alluded to, you know, we all sign up this and particularly as a surgeon, when you have a bad day, you know, I have a bad day, it's really bad for my patient. But as one of my senior residents once told me, you know, you got to remember that you got up this morning to help somebody. And I think that's what we all do. So I'm very, very pleased to see so many of you here to help us. So without further ado, we're going to go over some questions. Again, we got 3 minutes for each person's response.
Correct.
And then I got my watch out here to help us do that. And then we'll have some time when they're finished for about 5 minutes from the audience for questions from the floor. And if you get limited to short, close-ended questions, I know you all want to get up here and speak because you all obviously feel very passionately about the subject, but that will help us a lot. First question is that there are currently 12 million undocumented people in the United States. The Affordable Care Act specifically excludes these non-citizens and temporary workers from coverage. Many of these uninsured people rely on non-urgent care in hospital emergency rooms, of which we're very aware, or delay care, often leading to more costly care and poorer outcomes. What would you propose to remedy this most expensive way of obtaining primary and non-urgent care for these 12 million people in our country? We'll start, we'll alternate. Each person will have the pole position on questions. I'll start with Dr. Weinberg.
As a proponent of national universal health coverage in the U.S., funded by some sort of taxation, the solution to this problem is achingly obvious. Everybody in, nobody out means that any human being living in the U.S. would have health coverage. those who haven't had coverage before and therefore don't understand about what ERs are for as compared with a doctor's office can be helped to be steered to primary care practices for non-urgent medical concerns and preventive care.
Dr. Henson.
Thank you. First of all, I'd like to say thanks for having me over from Swedish. The second thing is I speak on behalf of me and not Swedish. And the third thing is Hugh's already given me a promotion. I'm actually the Vice President of Medical Affairs, not the Chief Medical Officer, but someday. So, yeah, I didn't get the memo, but that must have come out this morning. So, you know, from my personal viewpoint on the issue of extending health care to undocumented individuals in the United States, I think there are issues. And while it sounds really humanistic to say that anybody that lives in the United States should have access to health care, there are a lot of issues around this, and I would argue similar types of issues around the way we're extending care through the Affordable Care Act now. And you know, those issues are that as a policy initiative, the idea of extending rights to people in a country for which they're not legally present is very difficult. It feels good, but if you actually look at the ramifications of what a policy initiative like that is, what is it that we're saying to people? What is the unintended consequence of giving that to people who are in the country without legal status? And what other behaviors might that invoke? I think, you know, that really raises some very difficult questions. And it's not always the right thing to simply give things to people. And I think we all recognize that from our own lives. Another issue is that what are you going to give them if you give that to them? And by the way, you sound the alarm when I run over, because okay. I'm notoriously chatty at the microphone. So what are you going to give them? And the issue is that if you're going to give them Medicaid status, I would argue that that's not the right policy initiative for anyone in this country. I don't think Medicaid's the right answer. And if that's what they would get if they were to be given status in the U.S. healthcare system, then I'm not sure how much better Medicaid is as a program run by the government. I'm not, or you know, as currently constructed. I'm not sure how much better. And there's some evidence that in fact people who exist under the Medicaid payment system are probably not substantially better off than people who don't have any health care at all. And so it's not intuitive, it's not axiomatic that receiving government-funded status actually improves health care in these individuals. You can't prove that, I don't think. And so that's another issue. And then I think there's a major issue around fairness, and that is that somebody has to pay for that, right? And it's just a bitter reality that if you're going to extend those rights to people, there has to be some sort of engagement in lawful behavior in the society, and I think you have to consider that. How to fix the problem is much more complicated. I would say that it is only fixable in the setting of immigration reform, and I don't think that there's an easy way to fix it outside of immigration reform.
Thanks, Dr. Henson. Dr. Katz.
Ooh, can we just spend the whole hour on this?
Yeah.
So just to answer the question, I mean, I think if we had healthy politics in this country, we would fix the Affordable Care Act, and later on we'll talk about all the problems with the Affordable Care Act, of which there are many, but we would fix it. And one of the fixes would be this: we would extend coverage to this group of people who don't have coverage. I think it's an interesting sort of frame to think about the giving of coverage. See, I don't think of it as a giving of coverage. I think of it as social cohesion and protection. So we have a group of people here. We can debate whether they ought to be here, which is, I think, the immigration reform is important. We should debate whether they ought to be here and how, depending on how we answer that question, what to do at that point. But they are here. They are, by the way, working, paying taxes. They're actually giving into the system now. Good data on that. And they don't get anything back because, for example, they pay Social Security tax and they're not eligible for Social Security. They pay local, state, and federal taxes, are not eligible for any benefits. So it's not, to me, it's not a matter of giving. That's not the question. It's a question of what's the benefit to society of having everybody covered, regardless of their circumstance. And I think the benefits are extensive. We're not going to debate the data here about Medicaid, but actually I think there is substantial evidence that Medicaid is good for people to have. But it's clear that if the healthcare system is good for people, which is a reasonable question to ask, the key to our healthcare system is being insured. That's the financial key. And people who are working, their kids, regardless of their legal status, need access to that system at times. Right now, this group of people, this particular 12 million people, they're not the only ones who are uninsured, don't have that access, and we all suffer for it. We suffer because they get delayed care, which is more expensive in the most expensive place, and all those things. You all know that. So to me, it's not a matter of giving, but it's a matter of creating a cohesive system that's efficient, effective at making sure that people get the care that they need.
Very good, thanks. We'll take some questions from the floor. Yes, ma'am, right here in the aisle.
Well, I've heard that 60% of pregnant women access Medicaid for at least their first pregnancy. So I would argue that that is a huge benefit of being on Medicaid for both the mother, the child, and the family. So I have issue with the statement that people don't benefit from having coverage, Medicaid coverage.
So the point is that 60% of women access Medicaid for their first delivery. And so, in fact, it is beneficial, particularly those people in prenatal care. Anyone want to comment on that? Obviously, there's public health implications. You've got a contingent of people who are below the poverty level that are a significant proportion of your population milling around. It's also a public health threat to a certain degree. So those people having access to care is probably a pretty good idea. We have a lot of infectious disease experts around this place. I don't know if there's any comments from that cohort. Any other comments or questions? Yes, sir.
What does it cost us to have these people not covered? As Aaron said, everybody knows, but we don't know all the costs, I don't believe.
Right. What are the costs of currently for caring for undocumented people in our society? Does anyone know?
Well, I'm not sure exactly, but there have been a number of studies to look at how much more it costs families to finance, quote, charity care. So there's care for people who don't have an insurance card of one kind or another. And those range, but $1,000 a year per family is not an out of a crazy figure. So it's not
just dollar costs.
those are just dollar costs, right? I mean, there are lots of societal costs.
What is the statistic on how much GDP healthcare costs in different countries? And I know that Germany, for example, it's about 12 or 13% of the GDP goes towards healthcare, and here it's about 17 or 18%. Which is only implying that part of that is going to the uninsured because Germany doesn't have uninsured.
That's not, the uninsured are not why we spend so much money on healthcare. I mean, the uninsured, that's a big problem for sure, but that's not why we spend so much money. In fact, we spend much less on uninsured people than we do on wealthy people. So that's.
I think we'll get to that question with further questions that we're going to be talking about.
I think it raises an excellent question, though, about other industrialized developed countries and what they do with non-citizen, non-residents. And can you comment on, you're from Germany, what happens if you're not German and you get sick in Germany, what happens?
I'm afraid I don't know.
Yeah, you don't know?
Illegal. Or, I mean, which kind of not being German?
Well, that kind of gets us back to this whole immigration problem. I mean, there's guest worker programs in most industrial European countries, as I know, where you do have some type of legal status, and just as many people do. Yes, ma'am, in the back.
You know, I always get bothered by the term legal status, because I think if we go back historically, the only people that were really here legally were the Native Americans. So everyone else came as an immigrant. So when we start talking about these people should have rights and these people shouldn't have rights, it's like we've all forgotten that no one is native to this country except for the first people. So I don't like to talk about people in terms of people being illegal. I think that that's real problematic.
Yeah. Yes, sir.
Well, I'm a retired school teacher, and I know that I was an ESL teacher in South King County. So I know that in my classroom, I'd have a mix of kids whose folks came here under different kinds of paperwork. But I know that when a student would get sick and had the flu or something, could spread it to anybody in the classroom. And we picked up that if a student was from a family maybe without papers, at best they could go home and be sick and then come back. But a lot of times they couldn't go home because the folks are working at 2 jobs or more. We have to keep them. And it seemed to me that getting all those families health care cards they could go get well was the logical decision. Is there another solution besides giving them all a health care card so they could get to a doctor, which they couldn't otherwise?
Can you all hear well enough in the back? The question was, children, particularly when they get ill, people who don't have the right paperwork to access health care oftentimes get overlooked, or they seek care late. And if anybody would like to propose a solution for that, short of Dr. Weinberg's. Dr. Katz?
Well, I mean, there are other solutions besides solutions that involve insurance. I mean, we could robustly finance community health centers and make them much more available to a much larger slice of the population, and of course make sure that people know about them so that they feel comfortable going in. So, I mean, insurance is just it's a financing mechanism, but so there are alternatives to that.
All right, we're going to move on to our next question. As insurers ratchet down payments to physicians and hospitals, these providers are pushing back with a host of new charges, and we all see that all the time on our statements and bills, those of us who can maybe understand them. Ophthalmologists are increasingly levying separate refraction fees to assess vision acuity. Orthopedic clinics impose fees to put an arm in a cast or provide a splint in addition to the usual bill for the hospital visit. Hospitals apply a facility fee onto the billing for a clinic visit. In any case, as insurers and providers fight over revenue, patients often find themselves caught in the middle and are billed significant portions of these charges, acting as potential deterrent to obtaining needed care. What proposals would you suggest to remedy these new charges in an era of cost control? And we'll start with Dr. Henson.
Thank you. So I don't actually think that this is a cost control issue, but a shifting of who's paying for care. So, for instance, in my clinical practice, I'm seeing increasing numbers of patients who have, since 2014, have deductibles that are so high, and particularly so much higher, on average across the country, 50% higher than they were a year ago, that they'll tell me, from a brain tumor specialist, I can only do 3 MRI scans this year. So why is that happening? And the issue is that as currently constructed, the healthcare system needs a certain amount of money to run. Nobody would argue that it's the right amount of money. But the problem is that if you begin to change payment systems in a way that leaves open the possibility of substantial changes in who's paying for healthcare. And this is cost shifting. It's all it is. When people get a facility fee, that's cost shifting. When people's insurance costs 40% more than it did the year before, that's cost shifting some of the new things that we're doing onto the middle class. which is worthy of thought. And so what I see these issues as are cost-shifting issues, and the real answer to that is to my view, is to try to figure out a way to reduce the cost of care without necessarily redistributing who's paying for it in a way that's unfair to those people. So I think it's a cost of care issue, and the ability that this new legislation in particular has given to companies to shift costs. And it's not just insurance companies. I mean, this is also something that's happening where employers are shifting costs onto their employees. We as employees are becoming the people who are paying increasingly more and more and more for our health care. Perhaps it's a good thing, skin in the game, those arguments. In point of fact, if you have a significant illness, it costs a lot of money. Having skin in the game is a really bad deal if you didn't have it in the game last year, and maybe you can't keep the plan that you thought you had. And we all saw that sort of political drama play out. So the bottom line is that I think that we have to figure out how to reduce waste. 30% of healthcare, I don't know, maybe. We have to figure out how to reduce waste without killing innovation, without huge shifts in who's paying for cost for medical care. And that's likely the only way that we're going to be able, in this country, to reasonably control this issue of costs going up like this.
Okay, thank you very much. Dr. Katz.
Yeah, I think I agree that the underlying issue is sort of ever increasing levels of spending and sort of the unaffordability of that. I think that is the underlying problem. But we do have a healthcare system that fosters this kind of income-seeking behavior, and it's always been that way. And we have a healthcare system that's designed for that. It's designed to actually foster innovation. We can argue about whether some of that innovation is, helps us or not. But we have, many payers. We have many providers, and it's a system that is set up to encourage people to seek ways of maximizing their revenue or seeking their target revenue, and we shouldn't expect individuals or organizations to behave differently in a system whose rules are set up that way. So I come back to if we don't want this to happen, we have to figure out a way to really reduce the rate of spending increases and make things more affordable. And I think we're very conflicted about how to do that. In fact, you mentioned, John, this huge expansion of high deductible health insurance plans, so-called consumer-driven health plans. That comes out of a philosophy, a frame that many people have, that if people have more skin in the game, they will act as smart economic buyers, and that, like in other economic markets, will drive efficiency in the healthcare system. I think it's totally misplaced, that notion. I think the frame is wrong, and yet that's what drives those types of insurance plans. So really, we have to rethink that notion of how we get to cost control, because we are very inefficient. We have no consensus on that at this point.
Very good. Dr. Weinberg.
Well, first of all, manipulating payment rates for professionals and facilities to maximize income is actually the normal behavior of a for-profit business. In the regular part of the economy, this is controlled by the buyer's willingness or unwillingness to pay the higher prices. In other words, if the TV costs too much, you walk away. But when it's healthcare and much of it has already been delivered before you get the bill, that doesn't work. In this case, both the providers and the insurers are playing games to see what they can get away with. Remember, Stephen Brill wrote an article almost 2 years ago in Time magazine that illustrated the enormous prices that hospitals and some providers charge, just thought up out of the blue, to see what they can get. And as they go into negotiation with insurers to see how much the insurers are willing to pay. In a single payer system, if you look at systems around the world, including Germany, the agency running the system would be able to stop this behavior. The agency would have to pay professionals adequately, not necessarily handsomely, but adequately, to cover the hospital's expenses, or the healthcare system would collapse. There's an interesting article in this month's Pediatrics Journal about the state of pediatricians in China, where they're at the point of collapse because they are severely underpaying and overworking the pediatricians, and the pediatricians are walking away. So the system will collapse if you don't give it adequate money. But in Europe, at least, and the rest of the wealthy nations, they have managed to negotiate reasonable payment for professionals and reasonable underwriting of the costs of running hospitals, so that their systems run and provide excellent health care and cost in the neighborhood of half what our system costs.
Very good. Any comments on the rising amount of co-insurance, co-pays, deductibles? Are people seeing that yourselves? Can you comment? Comments, questions? Yes, ma'am.
I was just thinking about your example of, that you go in for a procedure, but you really have no sense of the cost. I just had a bunion surgery in April, and then I had to have a second procedure to have the hardware taken out. When I went to pay for the second procedure, they said, oh, we actually never charged you for the first procedure, so now you not only owe $300, you actually owe another $300. So they're asking for $600. How does a person plan for this? It's ridiculous. Just an example I've had recently.
Can you hear in the back? The comment was that there's no, you're given no idea upfront what anything's going to cost. And that's one of the problems, and there's a delay, and it's usually months delay before you get a bill. The bill's not obviously often not itemized at all. You have no idea when you're paying. If you can figure out the date and you kept records of what happened to you that day, perhaps that works. I recall when my cat got sick and the ongoing discussion back and forth with the veterinarian over the course of the afternoon and into the evening and wee hours of the morning. And every time treatment X wouldn't work, he'd say, well, that's $100. The next thing is an x-ray, and that's another $200. And then, well, the only thing left is to do an exploratory laparotomy on your cat, but that's $400. So there was complete transparency between the projected cost of what's going on. Obviously, we can't do that when somebody rolls into the emergency room, and we're a lot easier at giving people care up front. It's when the dust settles at the end that we all have to pick up the pieces in a very complicated system. If there's any other comments? Yes, ma'am.
I guess the other comment I would make, I think that there's just so many different factors at play, because as doctors, you guys also have the student loans or bills from your, just bills that you've racked up that you now have to pay for, which means that you're of course going to need revenue. I think some of the buildings that are, patients are now going into don't need as much as they have. They don't need to be as aesthetically, pleasing, not a bunch of waterfalls or things like that. And I guess the reason I bring this up, because I lived in London for 2 years, and I went into hospitals, and I had a GP, and their buildings weren't nowhere near as beautiful as ours, I would say, and had some procedures there. But when it comes to us in our country, so for some things, I just don't understand why we spend as much as money as we do for things that are not necessary when it comes to, paying for medical care. Like, we don't need an atrium. We don't need manicured lawns. And, we're coming in to get a procedure. I just want a professional who knows what they're doing. why are we paying this extra money that is for what reason?
Well,
If that
anybody want
makes
to comment on the why of beyond fish tanks?
I don't like fish tanks, and I think those are now discouraged by the regulators. But I think that it's okay to be different as a country than some other places, or different as an industry. It's no problem with that as I see it. I think if you tried to take that idea and say, we're going to regulate what hospital lobbies look like. Actually, I can see that happening. I mean, it's probably only a few years away, but let's imagine that, say, a government regulator wanted to do that. I think the asymptote of that are blocks and blocks of cement flats outside of Moscow. I mean, and I don't mean the communist thing. I'm just saying that if you say it's got to be utilitarian, you can have a Trabant in any color that you want as long as it's gray. Is that really the way this country operates? And I would argue that it doesn't. It's just not what, the people want options and choices, and we're accustomed to that. I think a lot of this, a lot of the cost thing, I'm just thinking about what Aaron said a few moments ago, is driven by the way people want to consume healthcare. I have family members who believe that if they're not in a doctor's office every day almost, that they're not, getting good health care. How do you look at that side of cost?
Yes, sir.
Regarding hospitals and innovation and so on, most national systems use global budgets for hospitals, and most of these systems are still private hospitals. So they've got global money that they can use however they want to try to attract customers to them. Wouldn't that kind of system work if we had a single payer system in this country?
I understand that
fish tanks.
Maryland is working on that now, I think, and it'll be interesting to see how that works. Yeah.
Would global budgeting help control costs? And really, I mean, a lot of it is the equivalent of advertising. I mean, I'll just interject a note myself. Is there something wrong when you go to the professional sports event where the tickets are $50 a piece minimum, and the major advertisers are healthcare institutions? I mean, it's kind of the public display of the fish tank phenomenon. Yes, sir.
Well, just quickly, because as you mentioned, with Dr. Brill's article and previous articles about this, we really do have 4 different types of healthcare, it appears, in this country. The German, Japanese model, von Bismarck, the biscuit, which is the British, the Canadian, and then just pay as you go. And does the panel see any gravitation with the ACA towards any one of those systems, given the fact that we are in a capitalist society that's driven by profit motives and things of that nature? Do we see healthcare in any different light now that the ACA has come into effect? In other words, are we seeing the ACA as pushing us towards seeing healthcare as something other than a profit-driven enterprise?
No. I just want to say, though, Hugh, you don't have to go to a sports affair and pay $50. If you pay $3 and go down to the bus tunnel,
Yeah.
Polyclinic, everywhere. It's the only ad now in the bus tunnel. It's very interesting. But back to your point. No, I mean I know that there are some political folks who see the ACA as clearly the next step before socialized medicine or single payer or whatever. I don't think so at all. I don't think in the drafters of the law, all 3 billion of them, I think they did exactly what President Obama said at the beginning. If you like what you have, you can keep it, which cemented the American healthcare system as it is pretty much in place, with some some changes. The coverage expansions are important, and some experiments to try to see if we can change the fundamental nature of how health services are provided. These so-called accountable care organizations, or ACOs, that you may have heard of, or patient-centered medical homes, are attempts at changing the incentive structure, strengthening the so-called alignment between different types of providers. But I don't think the Affordable Care Act changes the fundamental nature of the American healthcare system, which is based on private insurance. Anyways, you know what it's based on.
And that was our next question, and we'll just go to the other panelists. What do you think? Sherry, do you believe the ACA as a model, the Affordable Care Act, is sufficient to achieve the healthcare reform goals that are needed in this day and age, and why or why not?
In a word, no. As the Institute of Medicine wrote in January of 2004, the criteria for a quality healthcare system are: 1, universal, everyone included; 2, continuous, no gaps in coverage over time from cradle to grave; 3, affordable, the financial contribution from individuals and families is structured so that all can afford the cost; 4, sustainable, the system is structured in a way that is sustainable for society as a whole over time, meaning years; and 5, high quality, the healthcare delivered is of high quality for everyone and is also timely, effective, equitable, available, and culturally sensitive. This can be abbreviated, if you take the first letters of each of these, as UCASH. The Affordable Care Act, even if implemented as designed, fails to meet any of these criteria.
Dr. Henson. Well, Aaron kind of he gave us the answer. The next question was, do you think the Affordable Care Act is going to achieve the goals of health care reform?
Before you want that cleanup? I'm happy to do
I'll be sweep.
Okay, you're sweet. Different sport. Okay. No, I think the Affordable Care Act moves along on some of those dimensions. So the coverage expansion, Medicaid expansion, the subsidies through the health insurance exchanges, should they be upheld by the Supreme Court. I think those are good things. I think it's generally a very good thing to have more people have health coverage in this country. I think the provisions in the Affordable Care Act as they relate to quality improvement and efficiency are wholly inadequate. I just don't think there's enough there to get us along the way. So again, if we were in a healthy politics, every year Congress would be tweaking it so that we can do more on those dimensions.
So it sounds like there's unanimity around the idea that it's problematic legislation, and I do agree that it has changed the conversation around healthcare in the country, and I believe that is its most significant contribution is that we needed to move something off home plate, get it going down towards somewhere else. And I believe that ACA helped us to do that. So I'm happy about that. If you look at most other things that it tries to accomplish, I think Aaron laid those out actually Sherry laid those out very nicely. It's like expand coverage, make sure that there aren't gaps because you had a prior illness, and subsidize coverage for people that can't afford it. Those are, according to the Supreme Court, when they were initially looking at the first contest of ACA, the 3 legs on the stool. So if the Affordable Care Act had accomplished those things and stopped, it would have been quite interesting. But it's really hard to stop when you're writing a bill. So let me give you some interesting details. If you haven't kind of gone through this. And by the way, I'm, as you can tell, I'm no health policy expert like the people next to me are, but it's a 978-page bill that over 10 years, according to the Congressional Budget Office, costs $1 billion a page. So it's a $938 billion bill over the period of 10 years. So what's in that $938 billion? So I downloaded the Affordable Care Act. It's a 900-something page document. As I said, I didn't print it, small carbon footprint. I'm just using electrons to look at it. And I decided on an experiment in which I would randomly open the Affordable Care Act to a page and figure out whether what I read on that page seemed to accomplish any of the three legs of the stool. Expansion of coverage, making sure that people don't have gaps, and making sure that, that for people who can't afford the coverage, there's some help. First time I opened the page, well, you can imagine, you know exactly what I'm going to say. Every page that I opened dealt with some other issue in the healthcare system, like, for instance, they're going to set up a commission to look at safety and care in nursing homes. Important issue? Absolutely. Is it what the Affordable Care Act was supposed to accomplish in terms of expanding care in the country? I don't think so. So the interesting thing is that if you say, okay, what would an Affordable Care Act have actually cost if we tried to expand coverage and maybe also reach the 23 million people that we think are going to be left at the end of the process without coverage? If it had tried to do that, and my back of the envelope calculation off things that would probably wouldn't stand the analysis of a healthcare economist, are that the bill would have cost about a third what it did. And so, you know, there are other issues. Why is it that we're using Medicaid type coverage to expand care? What about all of the issues around the exchanges and how people interact with those? What about the cost shifting that's going on, which is, in my view, is a really, really big deal. So, you know, good in terms of getting things moving. I think it helped get the conversation moving. I think that it tried to bite off way too much and ended up not accomplishing some of the things that it needed to. So I think, you know, some healthy reform would be a very good thing for the Affordable Care Act. I think it could be pared down and it would be more effective. It perhaps wouldn't pose an entirely new threat to the debt load in the country, which is, you know, you may not like to talk about that, but it's really a big issue, how quickly that's growing. And so anyway, I think it's a good place to start. I'd like to see more of those three legs emphasized in what the bill tried to accomplish, the law now tried to accomplish. And so I've probably gone over here.
Yeah. So it's good. I think Matt brought up the 4 essentials of T.R. Reid's book, and the name escapes me right at the minute. Anybody?
The Healing of America.
The Healing of America. That's a good treatise on the issue. I mean, if you want to read another one about the bill itself, it's kind of a blow-by-blow by John Guyman, our Chairman Emeritus of Family Medicine, called Hijacked: How True Healthcare Reform Was Stolen from the American Public. And you read that book, and it's very frightening. Bob, hang on, we're going to do one more thing, and there's one last question we want to address. We'll drill down, we'll finally get back to the essence of this gathering, which is ethics. And here's the question. We all know that among advanced industrial nations, the U.S. is the only one in which residents can be denied treatment because of the inability to pay, often jeopardizing their life, health, and family's financial and emotional well-being. Do you believe that this is a morally and ethically defensible state of affairs? And if not, what do you think it would take to remedy this situation? I think that kind of brings us back to the fundamental essence of getting together. Is the situation good right now? If not, what can we all do to help rectify it?
Do I go first?
Yeah.
Well, as the single payer advocate here, my answer is no. This is not morally and ethically defensible that we essentially deny health care to people who can't afford it. Sure, if they show up ill on the doorstep of the Harborview ER, we don't ask them to please move over and die quietly. We do take care of them under that, but because there are all these financial barriers, people tend not to come, and they tend not to seek health care in many cases, even when they really need it. And essentially, only other nations to do this are those with inadequate resources to provide all the care that their populations need. We are not such a nation. We do have the resources. We are the wealthiest nation on the planet. We do have the ability to tax ourselves, to pay for a healthcare system that can be there as needed for every single person living in America. And it's interesting, China is a special case and a warning about how badly healthcare systems can be mismanaged. I just read an article in Pediatrics that came out this month, and I urge any of you who have access to pediatrics to read it. Chinese pediatricians face a crisis should they stay or leave. They are being severely overworked and underpaid, and they are leaving pediatrics in droves over there, and the system is falling apart. Not only that, but patients and families are getting so angry that they come into hospitals and kill doctors as a result of what they perceive as failures in the medical system. I would hope that we don't go there, but it can be even worse managed than ours is. A single-payer national health coverage system could and should be required to provide needed health care with only affordable financial contributions from individuals. And I also want to add that as a physician, I feel very strongly that it would be a violation of the Hippocratic Oath that I took when I got my medical doctor degree to deny health care to anyone because they couldn't pay.
Dr. Katz.
Well, I mean, I think the answer is self-evident, right? So I think that this is an issue about what we do as a society in the face of a system that does, in fact, do wallet biopsies, and that's, again, we get into. We have conflicting values in this country that I think get in the way of reasonable solution. I think on the one hand, we are a very caring society, and by and large, there's a few outliers to this, but by and large, we will not allow people to die outside of the emergency room for lack of care. But we also have values that, we know the pull ourselves up by the bootstraps business, and one of the questions we're not getting to, but I think is very, very important, is the notion of fairness. And what does fairness mean in our society? And we don't agree, actually, on what fair means in our society. We have, I think, valid, reasonable, but fundamental differences across segments of the society about what that means. And if you can't agree on what fairness means, the polls are kind of, fair means I don't pay for your problems that I didn't help cause. That's one notion of fairness. And the other is that, we should all support each other fairly. We should all contribute to the common good. And we have these different strains, and that really makes it difficult for us to find a solution to what I don't think anybody. There's a couple of people who might say, yeah, this is just a fine situation. It's their problem. There are a few people around that, but not many, and that's not the vast majority of Americans. So I think it's really just gets back to the discussion about healthcare reform. The Affordable Care Act is what's the right way to reduce that crazy problem.
Dr. Henson.
Thank you. So the idea of somebody going bankrupt personally because of healthcare costs is pretty deeply objectionable. I think most people would agree with that. The issue comes is the idea of bankruptcy in this circumstance is used to infer a catastrophic financial event that was so overwhelming that it took somebody from a healthy financial position to one that's not. So if you were to attack that particular problem and you had a risk pool for people who come down with, say, acute leukemia that need $500,000 worth of care, many of us in the room, if we had to pay that, would find ourselves in chapter whatever it is that, I forget which chapter people go into, but that chapter. So there should be a limit to which, above which people don't have to pay for things that are very serious that happen to them, very expensive things. This happens to my patients a lot in terms of expensive, the chemotherapy, the Avastin, the MRI scans, et cetera, it's expensive stuff. But it would need to be means tested. Now it begins to get complicated, right? So now we're going to means test because it turns out that this person owed, a few $1,000s for their medical care, but they had bought things that they couldn't afford. This is a common American problem, right? That in fact, their bankruptcy is not due to the financial costs. So you can see where I'm going with that. I mean, it's certainly possible that there would be many circumstances in which that would happen to people because of other factors that are not directly related to the cost of the health care. So I think that I am adamantly opposed to watching people go bankrupt. I want to make sure that we understand exactly what it is that is causing them to go bankrupt. And the other thing to say is that bankruptcy is not the same as death. People don't die when they go bankrupt. Companies don't die when they go bankrupt. What it is that it says to your creditors, I'm going to pay you. And then the hospital or whoever is on the hook for a payment that's not going to come in. And does it have implications for that individual or that family? Certainly it does, but bankruptcy sometimes I think in conversations like this, or bankruptcy concept is used as a permanent devastating event from which people can't recover, and that is not the technical sense of what bankruptcy is at all. So those 3 points I think for me would be important.
I think we're coming to the end of our time slot. A lot of very good points, I think, that are made. A lot of very good resources. Matt mentioned the 4 essentials from T.R. Reid's book, The Healing of America. Sherry's had some references here from pediatrics that just acutely do that. The bankruptcy study, many of you are familiar with, is kind of the banner under the serious healthcare reform movement. The irony of that study, of course, is that is the essence of it was that more than 51% of personal bankruptcies filed in this country cite medical bills as a major cause of their bankruptcy. The true irony is, of the people who filed bankruptcy, 76% of them had health care coverage of some sort when they took ill. So just the fact that you think you're insured, and this is of course in the pre-ACA era without the bronze and balsa wood plants.
Lead.
Or lead plants, as they would say. So I think, and again, I mentioned John Guyman's work, Hijacked. He's got a whole host of books, and anyone else that has any other references, feel free to email me. My email address is hughfoy@uw.edu. And I'd be happy to post them. There's a variety of resources. So most importantly, I want to thank all of you for coming today. I want to thank Dana, Iorio, and the Ethics Committee for giving us a forum to start this discussion. And of course, thank all of our panelists for coming.
I do think it's just a start. This is just a start of the discussions that we all need to have.